With rising cases, high fatality, and mortality of COVID-19, the pandemic, the disaster, it has affected all of us in all the walks of our lives. But we do have a good news. We can curb the disease and save all our patients. The information in this video is derived from evidence-based studies and my own clinical experience. Hello everyone, I am Dr. Shan and I have been treating COVID-19 patients successfully, age ranging from 17 months to 76 years, irrespective of the comorbidities the patient had and without any post-COVID complications. Let's have a look into it. With changing treatment protocols and new strategies, still we are facing a loophole. Let's take a dig into the pathogenesis. The working of the virus. What exactly is COVID-19? It's a virus causing damage. But the question is, why is it different from any other virus? Viruses are known to be self-resolving. What is the difference? Going into the depth, the route of entry is respiratory tract via mouth and nose, and the transmission is via droplet infection from person to person in close contact, and the primary site of attack is lung. To this viral attack, there is a counterattack by body's immune response to kick out this virus and prevent infection. That is our immunological response to any pathogen that enters our body. But in case of COVID-19, this response is hyper. It is an exaggerated hyperimmune response elicited by the body to the virus, leading to hyperinflammatory state and the related consequences further. The problem is the body's hyper response. It is far more dangerous than the virus itself. To understand this better, the same virus presenting differently in different people in terms of presentation, severity, recovery and fatality. So how the body is reacting depends on the fatality of the virus. Secondly, virus is self-resolving if you survive the first 7 to 10 days and prevent inflammation-induced organ damage. So the goal is to triage the organs, especially to save the lungs. So our first target is to reduce this body's hyperresponse or control it. The second most important pathogenesis is HLS syndrome, hemophagolymphocytosis syndrome. HLS is seen in many bacterial and viral infections. But what is HLS? It is cytokine-induced hyperinflammatory state presenting as high-grade continuous fever, pancytopenia, hyperferritemia, increased LDH, because of increased destruction due to inflammation-induced organ damage. This picture is similarly seen in COVID-19. HLS and COVID-19 as per studies are very closely associated. Our next factor on board is hemozoin. Elevated levels are seen in endemic malarial countries, which are further increased in conjunction with various infections. This hemozoin is toxic to cells and especially erythroid precursors that result in its damage and destruction and thereby results in increased levels of iron release. This probably explains the high levels or raised levels of ferritin in blood in COVID-19. All these three factors are interrelated and acts like in a vicious cycle, resulting in systemic inflammation which adds on to each other. This further leads to free radical damage and development of hyperinflammatory state, leading to MODS, multi-organ dysfunction syndrome, because of organ hyperperfusion, especially the lung is targeted, so it leads to ALI, acute lung injury. Cutting long story short, when the questions asked, most important organ that comes to our mind are our heart and brain. But the most delicate, fragile organs are the lungs. In present COVID-19 scenario, the hero organs are our lungs. They are involved in gaseous exchange and oxygenation of every cell of the body, and failure of which leads to damage. So basically they are the factory of oxygen helping every cell survive. Secondly, they are involved in removal of large quantities of metabolites, acting like purifier of blood. Efficient functioning of lungs is required for survival. But lungs are highly susceptible to damage by any external stimuli, be it a chemical, a bacteria or virus, as in this case. On entry of virus into lungs, it damages and destroys the lung lining, resulting in increased capillary permeability, pneumonia-like condition, leading to ARDS, acute respiratory distress syndrome, and progressive lung failure. Acute in the sense damage is in very short time, so hurry up. We need to save the lungs. The more the virulent strains are, the acute the condition gets, and the time to save it gets reduced. So every second counts. So our primary intervention should be to save these lungs. If you save the patient in first 7 to 10 days from inflammation induced organ damage, you win the game against virus and the patient is safe. Now the question is, what is the problem that has to be dealt first? Is it either the virus or the inflammation? Here, the virus is inciting the body's protective immune response via MHC1, an interaction between T and B cells, which is normal. But in COVID-19, it's too intense to handle this reaction. It is like instead of a bullet to kill the virus, it's using a missile, more of self-damage than to the virus. But why is it leading to such an intense hyperinflammatory state? The body is confused as to what exactly is this new pathogen to which the body has never been exposed to in its lifetime. And it irrationally generates an erratic, dysfunctional immune response to kick the virus out of the body, but instead ends up in hyperinflammatory state called cytokine storm mediated by IL-6, which is more or less similar to autoimmunity disease. Going further, hyperinflammation and its consequences. It leads to oxidative injury, resulting endothelial damage, and furthermore activation of coagulation cascade and multi-system involvement. This very well explains different presentations seen in COVID-19, with involvement of brain showing stroke, heart with SCD, sudden cardiac death, NMI, intestinal gangrene, renal involvement, etc. The same virus causing so many presentations. So it's not limited to lungs, though it begins with lungs but later involves other organs too. Few of the important pathways that lead to hyperinflammation are TNF-alpha, IFN cell signaling, IL-6 STAT3, TMPS, and example hemozoin, which we have already known, TLR, and other critical inflammasome activation pathways. To understand inflammation, its progression and outcome, let's divide it into 3 categories: Category 1, Category 2, Category 3. Category 1, first 1 to 5 days, initiation of inflammation, mild to moderate infection. It includes asymptomatic RT-PCR positive, HRCT positive, primary contacts or symptomatic patients with SpO2 more than 90% but stable, symptomatic patients with dropping SpO2 but more than 90%. They may have raised levels of IL-6 D-dimer ferritin to a certain level. Intervention at this level saves 90 to 95% patients with no irreversible damage and without any post-COVID complications. So hit the nail hard here. Category 2, 5 to 10 days, it's full-blown inflammation. Intervention here can save 70 to 80% damage, might or might not be irreversible. Post-COVID complications may be present. It includes patients with dropping SpO2, require oxygenation and high-end drugs. IL-6 and D-dimer are highly raised. Category 3, more than 10 days, cytokine storm, very severe stage, requires NIV or ventilatory support, unstable SpO2s, and vitals are also unstable with raised levels of inflammatory markers. Intervention at this stage, prognosis gets reduced to great extent, irreversible damage and post-COVID complications are seen. At this stage, the damage has really hit hard. So we can derive it as Category 1 is our medical stage, Category 2 is our oxygen stage, Category 3 is our interventional or invasive stage. We should focus on treating maximum cases at Category 1 and preventing the progression of Category 1 to Category 2 or Category 3. We can do this by early intervention and prompt treatment, without neglecting the basic fever and danger signs like breathlessness, etc. And moving further, the overactive body's response and IL-6 induced weakness leads to ineffective immune system, resulting in secondary bacterial infections and rebound infections of previous dormant infections such as typhoid, malaria, RTI, etc. So we need to treat these infections judiciously with basic early oral prophylactic antibiotics instead of late IV high-end high-dose antibiotics later. Because of varied presentations, the treatment becomes a bit difficult, and diagnosis too. Varied presentations in COVID-19 are due to activation of coagulation pathway, and this even explains vaccine-associated clot formation, as vaccines mimic COVID-19 infection to generate antibodies. So treat COVID early with anti-inflammatory and antibiotic drugs at low doses to modulate the body's hyperresponsiveness. It's a pandemic. Everyone is or is going to be affected. So the drug use should be effective at initial stages. It should be safe, requiring no monitoring, with lesser side effects, cheap and easily available, commonly used. So I would like to reintroduce our savior drug, CHLOROQUINE. It has helped my patients to gain normal health by limiting the inflammation and worsening of their symptoms. It has prevented SpO2 drop, instead helped revive it. Patients has responded within 2 days and had excellent prognosis only after 2 doses. Patient was in perfect health within 3 days of treatment if treatment was started within 3 to 5 days of symptom onset. Few aspects we need to ponder over are: WHO has rendered it ineffective. But the question is, in which population? The studies were carried out in uninfected patients and as prophylaxis and in hospitalized patients with severe illness. But no study was done in mild to moderate symptomatic cases and RT-PCR positive or HRCT positive asymptomatic patients, in which the drug is doing the magic. Moreover, the studies are carried in non-endemic Western countries unlike ours. We cannot deny the variations because of the ethnicity and geographical conditions. Moreover, study shows no evidence of QT prolongation leading to fatal tachyarrhythmia, especially in Indians. Action of drug might vary as ours is an endemic country. The pros of the drugs are, our country is endemic to malaria, so we have been using this as an over-the-counter drug. We are well aware about the pharmacodynamics and kinetics, so better understanding and monitoring of the effects can be done. Safest than the most proposed higher-end drugs now. Safety profile in wide range of population, like it can be used in elderly, pregnancy, children and patients with comorbidities, which is not an exception. Care should be taken in blood disorders and QT prolongation induced tachyarrhythmias, in which this is contraindicated. Not considering the antiviral properties, studies show CHLOROQUINE have anti-inflammatory and immunomodulatory effects. As we know, HLS is closely associated with COVID-19. CHLOROQUINE is used to treat HLS as well. COVID is associated with raised levels of hemozoin. As in malaria, it does inhibit the production of hemozoin. And the most important point to be focused is CHLOROQUINE attenuates pulmonary vasoconstriction induced hypoxia, which helps in better oxygenation and survival of the lungs. So we have an ideal drug which acts on all the pathways that lead to hyperinflammation. COVID-19 infection shows picture similar to ARDS, which is more or less similar to NRDS, resulting in hypoxia and breathlessness because of inflammation induced organ damage, leads to MODS, leads to increased mortality. Raised levels of IL-6 is related to extreme weakness, most common presentation seen in COVID-19. So borrowing time is important to save from inflammation-induced organ damage. Our next goal is to save the lungs with early low-dose steroids on board. Pros: it's more effective in preventing damage rather than post-damage repair. It protects from free radical injury throughout the body, not just lungs. It has lesser post-COVID complications and organ damage. Myths and hurdles we need to cross: drug is dangerous but death is deadly. What do you mean by judicious use? It means beneficence. Initial low oral dose for short time are safer than longer high dose IV used as mainstay treatment in later stages. So we need to avoid this. The notion that steroids is equal to side effects and RMPs use the drug needs to be taken care of. Steroid protects from permanent damage and associated post-COVID complications. It's a life-saving drug. In present scenario, we are using high-dose IV antibiotics and steroids which are inhibiting the immune response completely, leading to opportunistic infections like mucormycosis and antibiotic resistance. This can be dealt with early prevention. and intervention. Free radical injury and inflammation go hand in hand. We need to deal with this with vitamin C, which helps in free radical elimination and protection of vitamin E, which prevents cellular membrane damage. Vitamin D is known to have an important role in mast cell stabilization and thereby prevention of inflammation induced organ damage. Antioxidants to have must on board. To conclude, a combination of chloroquine and low dose corticosteroids in initial stages of infection is very effective. Golden rule is first 3 days of onset of infection. Save the patient from inflammation and infection.